T cells are able to infiltrate the tumor mass, unfortunately, they cannot properly function because there are some components of the tumor microenvironment, either cellular component but also other features that are able to inhibit their activity. And among them, Dr. Conforti Lab has a long-standing history in studying the effect of hypoxia and adenosine on T cell functionality. So we know that in the tumor cells are highly proliferating cells that exceed the availability of oxygen, and so the tumor microenvironment is characterized by hypoxia. And this hypoxia has been shown to block the activity of Kv1.3. Moreover, hypoxia is also responsible for the accumulation of adenosine, and adenosine, after the interaction with the A2A receptor, blocks the activity of KC111. So both these elements of the tumor microenvironment, adenosine and hypoxia, are able to block the potassium channels that are needed for the T cells to function properly. Moreover, in the last years, we have shown that in HNC, so in patients affected by head and neck cancer, there is a defect in Kv1.3 and calcium fluxes in the tumor that infiltrates the tumor mass. And there is also an increased sensitivity of these cells to the adenosine that is mediated by KC111. And all these events lead to a defect in T cell effector functions and chemotaxis. So in the last years, we were interested in studying the effect of the axis PD-1 and PD-L1 on ion channels and the effect of anti-PD-1 therapy on T cell ion channels. Also because it has been shown in the literature that hypoxia is able to increase the expression of PD-L1 and adenosine of PD-1. So we took advantage of our collaboration with Dr. Weiss Draper, that she's an expert in cancer therapeutics and head and neck cancer, and my colleagues showed that a patient who received, HNC patient who received pembrolizumab and responded to treatment, and for response we mean a reduction in viable tumor more than 80% at resection, had an increase not only in KC111 that was observed also in non-responder patient, but also in Kv1.3 and calcium fluxes. So responders patients as a sort of specific ion channel signature that could predict their capacity to respond to the treatment. We were able also to reproduce these results in vitro, and in fact circulating CD8 T cells of HNC patients that were treated with pembrolizumab show, as you can see on the left, an increase in Kv1.3 and KC111 currents, and in a subset of patients also the calcium influx that went into the cells was higher after the treatment with pembrolizumab and anti-PD-1 compared to the control. So all these data are referred to circulating CD8, so peripheral blood T cells. So then we asked which was the relationship between ion channel and PD-1 in tumor infiltrating lymphocyte. So the relationship between the expression of the ion channel and PD-1 in these stills. So we performed some experiment of immunofluorescence, staining head and neck cancer samples, tumor resection for PD-1, granzyme B, that is a marker of cytotoxicity for T cells, CD8, Kv1.3, and pancitocleran in order to detect the tumor. And then we were able to quantify the expression of PD-1, granzyme B, and Kv1.3 on the CD8 cells in order to define cells, CD8, that were PD-1 high or low, granzyme B high or low, Kv1.3 high or low. And here the results. So on the left you can find that the percentage of cells CD8 that were higher in Kv1.3 was more abundant in cells that were also PD-1 high compared to PD-1 low. And when we went to study the cells that were not only high in Kv1.3 but also in granzyme B, also this percentage of cells was more abundant in PD-1 high cells compared to PD-1 low cells. And so perhaps we could speculate that using anti-PD-1 therapy, we are able to disengage from the binding to PD-L1 this population of cells that overexpress PD-1 that then will become active and able to fight against cancer cell. We also, but as you know, the Kv1.3 is not only the only ion channel that is involved in the activity of the T cells. We have also RA1, KCTP1, and STIM1, and there is an initial evidence that also RA1 as Kv1.3 is more expressed in PD-1 high cells compared to PD-1 low, and the same was not evident for KCTP1 and STIM1. To conclude, we have shown that the circulating T cells of HNC patients who responded to pembrolizumab show an increase in the activity of this potassium channel, calcium fluxes, and also were able to chemotact better compared to non-responder patients. Moreover, in vitro studies confirmed that pembrolizumab affect ion channel in T cells of HNC patients, increasing either the activity of KCTP1 and Kv1.3 and in a subset of patients the calcium fluxes. Moreover, through the experiment of immunofluorescence, we observed that the cells that were higher in expression of Kv1.3 were more abundant in PD-1 high cells compared to PD-1 low cells. I would like to thank you, my mentors, Dr. Conforti and Dr. Weisdraper, and all the past and the present members of Dr. Conforti Lab. A special thank to Dr. Cimote, the Department of Internal Medicine and the R38 program, and also the Division of Nephrology and Hypertension, the University of Cincinnati Cancer Center, and the Core for Live Microscopy. Thank you.
Thank you very much. So I think given that we got a little bit of a late start today, we probably have time for one question per presentation. So if we have any questions from the audience, feel free to unmute yourself and ask away.
Actually, since we're in a webinar, I'll have to unmute you. So go ahead and put in your questions in the Q&A. And while you're doing that, Dr. Chirra will answer them. But I do know that Dr. Rubenstein is on the phone and would like to say something. So I'm going to allow him to talk. Go ahead, Dr. Rubenstein.
Hi, everyone. Sorry about that. I had some technical issues over here at the VA, and I apologize. Anyway, so you guys all got to see how great Martina is. We're very excited to have her on board. She comes to us initially via Italy. She did great work with our HEMONC staff, and it's been fortunate for her not only as medicine resident, but also as our first R38 trainee. So we're very excited, not only for her specifically doing great work, but also to have a broad spectrum of physician scientists joining us. And Martina is doing a spectacular job as well. And I apologize for technical issues I had earlier.
Don't worry, Dr. Rubenstein. We all have technical issues today because UC is having technical issues. So thank you for coming.
Thank you so much.
I saw that. Yeah, good that we got it all together. So yeah, thank you and great job, Martina.
Thank you. Jason, if you'd like to introduce the case scholars, that'd be great.
Sure. Actually, Jessica, do you want to take the lead and talk about the program real fast for us, or do you want me to do that? You're more than welcome to.
Oh, yeah, Jessica.
I will just say hi to everyone and welcome to the K Scholars and MSTAR Scholars Grand Rounds. I apologize for my technical difficulties also. Thanks for the younger generation for helping me get on. And the K Scholars program is a program that's funded by the CCTST to train the next generation of clinical and translational researchers. And we have 3 of our stars presenting their work today. So Jason and I co-lead the program. I'm going to be stepping down. Dr. Meg Zeller will be taking my place to continue leading with Dr. Blackard, and he'll be introducing our scholars. So welcome, everyone.
Great, thank you. So our next speaker is Arun Jose. Arun is here in the Department of Internal Medicine with me. I say here because we're in the same department. He's in the Division of Pulmonary and Critical Care and Sleep Medicine. So thank you, Arun, and I'll let you take it away.
Thank you so much. Let's see if this works. Technical difficulties have been par for the course. So you can see the screen, yes? Okay, great. So I'm going to discuss biomarker discovery in Port-O-Polymer hypertension. I'm from the University of Cincinnati Pulmonary Critical Care and Sleep Medicine Division. These are my disclosures. We can look at them briefly. So, in terms of background, portopulmonary hypertension is an unusual variant of pulmonary arterial hypertension, a disease that affects the blood vessels connecting the heart to the lungs. Portopulmonary hypertension is unique in that it occurs exclusively in those patients with underlying liver disease. It also happens to be quite bad, boasting the highest morbidity and mortality of all PH subtypes, and also it is fairly poorly responsive to targeted therapy. It is unique, however, in all types of pulmonary arterial hypertension in that it occurs specifically in people with underlying liver disease. However, if you look at the lungs of portopulmonary hypertension patients, they seem to have the same changes in their pulmonary vasculature that other types of pulmonary arterial hypertension have. So, although it occurs exclusively in liver disease patients, it seems to reflect the same underlying pathology at the level of the lungs. Um, we don't know a lot about portopulmonary hypertension. The mechanisms of disease pathogenesis and exactly what links the liver to the lung is unclear. It is believed that there are some sort of circulating vasoactive mediators that are either secreted by a diseased liver or bypass metabolism from the diseased liver, enter the systemic circulation, and affect vascular remodeling at the level of the lungs. But that's all conjecture. We don't really have a lot of data about that. So our premise in this study is that given the importance of the liver in portopulmonary hypertension, we theorize that pathogenesis involves some substance either created by or interacting with liver cells that enters systemic circulation and affects disease pathogenesis at the level of the lungs. And so we approach this by the application of next generation sequencing, specifically single nuclear RNA sequencing, and validation in large disease specific biorepositories to characterize this potential substance as a novel disease specific biomarker. The main clinical questions we hope to answer with this work are one, how to discriminate people with portopulmonary hypertension from non portopulmonary hypertension liver cirrhosis, and from non portopulmonary hypertension pulmonary arterial hypertension, which is generally quite challenging in practice because a patient can come in with liver disease and be at risk for portopulmonary hypertension, but unless you proceed to an invasive right heart catheterization, there's really not any good way of saying whether or not they have portopulmonary hypertension, which has significant bearing on both their prognosis, their response to treatment, and potentially the candidacy for liver transplantation. The second clinical question we aim to answer uh, is there a prognostic marker of disease severity that can be used to guide treatment response in this subtype of pulmonary vascular disease? The current clinical standard for pulmonary vascular disease, which is natriuretic peptides, are generally quite nonspecific, and they can be elevated just as a consequence of liver disease and portal hypertension with hypervolemia, and so they don't serve very well in this subtype of pulmonary vascular disease to prognosticate or to guide treatment. So much of that is left up to clinical judgment. So we applied single nuclear RNA sequencing to a cohort of 3 portopulmonary hypertension and 3 non-portopulmonary hypertension liver cirrhosis tissue samples obtained at the time of transplantation. The characteristics of those patient samples are seen here in this chart. As you can see, they're relatively comparable in terms of age, and there's a good distribution of types of liver disease. The pulmonary vascular patients had appreciable metrics of disease severity and were on pretty substantial amounts of targeted therapy, so they appeared to have a good burden of pulmonary vascular disease, as expected, as they were undergoing liver transplantation. There is a discrepancy in terms of ethnicity and gender across the groups, so that is something to keep in mind. The SNAP frozen tissue was subjected to cold enzymatic digestion, and then the Sincera pipeline and the syrup package were used to generate the single nuclear RNA sequencing data and cluster it for analysis of differential gene expression. Cluster identities were based on marker genes and also previously published literature on human liver tissue single cell RNA sequencing. And the resulting plot you see here, so each colored dot is a single sequence nuclei. There's about 49,000 nuclei in this plot, and they are clustered and named based on their marker genes. And we focus specifically on the perivascular cellular clusters because those were believed to be the most relevant to disease pathogenesis and the closest to the vasculature. So if there was a secreted substance, these might be the likely culprits for generating them, namely the endothelial cells, the stellate cells and pericytes, and the cholangiocyte clusters. So we focused on these clusters and we identified differential genes that were unique to the Port-O-Polymer hypertension liver cells relative to the non-Port-O-Polymer hypertension control cells. And taking that list of differential expressed genes from these clusters, we constructed cytoscape maps to identify significant pathways of interest that were upregulated based on this predicted gene mapping. And these pathways were ones that we believed would influence the pulmonary vasculature and were good candidates for identifying biomarkers, namely affecting of vascular endothelial growth factor signaling, or vascular endothelial cell growth and differentiation, or vascular smooth muscle growth and differentiation, as these are processes that occur during the pathogenesis of pulmonary vascular disease at the level of the lungs. We then took these networks, cross-referenced them with the human circulating plasma proteome to identify candidate circulating peptide biomarkers for further validation. And in the plot you'll see that follows, the intensity of color on a yellow to red scale corresponds to the log fold change of upregulation in the Port-O-Polymer hypertension cells versus the control cells. So you see here the overall map of upregulated differential expressed genes that are unique to the Port-O-Polymer hypertension cell clusters relative to the non-Port-O-Polymer hypertension control clusters. And simplifying it out to focus on the circulating peptides, we end up with a simplified map here. And you can see that there are a couple of candidates that are fairly upregulated in the Port-O-Polymer hypertension cells. Put another way, these are a couple of select circulating peptides that we selected for further validation, and you can see they are upregulated in various Port-O-Polymer hypertension cell clusters of interest, and they also correspond to pathways of interest that we were focused on, such as vascular endothelial growth factor regulation and cellular differentiation and migration of vascular cells. So then taking these candidate biomarkers, we validated them in a cohort of samples from the pulmonary arterial hypertension biorepository at Children's, as well as the University of Cincinnati liver cirrhosis biorepository. So we used a sample of 80 Port-O-Polymer hypertension subjects, 50 non-Port-O-Polymer hypertension liver cirrhosis subjects as controls, and 40 idiopathic pulmonary arterial hypertension subjects as controls that have pulmonary vascular disease that is not Port-O-Polymer hypertension, in order to see if biomarkers are able to discriminate Port-O-Pulmonary hypertension from other groups and if they have any association with disease severity in the Port-O-Pulmonary hypertension specifically. We used N-terminal pro-BNP as the reference biomarker, as this is the clinical standard natural peptides that are used in pulmonary vascular disease for assessing disease severity and prognosis, and to some extent for screening. Regression models were adjusted for demographics and body mass index. And this is the characteristics of the cohort. As you can see, they're relatively well matched in terms of gender and age and BMI. There are some racial disparities. The non-cirrhotic Port-O-Pulmonary hypertension group has appreciable amount of synthetic liver dysfunction, and the pulmonary vascular disease cohorts, both idiopathic and Port-O-Pulmonary, have appreciable amounts of pulmonary vascular disease as measured by the mean PA pressure or the pulmonary vascular resistance. When we looked at FLT1, the gene that encodes VEGF receptor type 1, we see a significant difference in the Port-O-Pulmonary hypertension group versus the cirrhotic group, and also a borderline significant difference between portopulmonary and idiopathic pulmonary hypertension patients, suggesting that this may be a candidate biomarker for further validation. And we see the same thing with protein kinase C alpha subtype, in that the portopulmonary hypertension patients appear to have the highest levels, particularly relative to the cirrhotic patients. There was no difference across groups significantly for N-terminal pro-BNP. It did not appear to distinguish one group from another. When assessing disease severity in this cohort by mean pulmonary pressure or pulmonary vascular resistance, there was a significant linear correlation between protein kinase C alpha and both mean PA pressure and pulmonary vascular resistance. Specifically in the portopulmonary hypertension subtype, there was no association between protein kinase C alpha levels and either mean pressure or vascular resistance in the idiopathic PA patients, and there was no association between BNP levels and either mean PA pressure or pulmonary vascular resistance in the portopulmonary hypertension subtype, groups suggesting that protein kinase C alpha levels may be a marker of disease severity unique to portopulmonary hypertension and superior to BNP. When looking at discriminatory value, both FLT1 and protein kinase C alpha appear to discriminate portopulmonary from other groups, including idiopathic and non-portopulmonary cirrhotics. And that was true both in a univariate regression model and after adjustment for age, gender, race, and BMI. And put another way, a model that incorporated just protein kinase C alpha and FLT1 along with demographics was able to provide a high level of discrimination for portopulmonary from both idiopathic and cirrhotic non-portopulmonary patients, suggesting that the combination of FLT1 with protein kinase C alpha may serve as a valuable discriminatory biomarker for portopulmonary hypertension, particularly valuable in challenging clinical scenarios. So in conclusion, the use of single nuclear RNA-seq and analysis of perivascular portopulmonary hypertension cells identified candidate biomarkers, protein kinase C alpha and FLT1, that may be novel disease-specific biomarkers in portopulmonary hypertension. In terms of future directions, we hope to validate these biomarkers in a secondary biobank, as well as explore some additional biomarkers that were downregulated in the portopulmonary hypertension cells, namely related to vascular endothelial growth factor receptor type 2 and platelet-derived growth factor receptor B. And we also hope to examine the receptor ligand interactions between these perivascular cells to identify additional candidate biomarkers for validation. This work would not have been possible without the help of many, many people from many departments, both at UC and at Children's. In particular, I'd like to thank my mentors, Dr. McCormick and Dr. Elwing, who have been very helpful since I joined UC at every step of the way. Thank you. Let's see, stop share. Cool.
Thank you, Arun. Do we have any questions from the audience? I think Stephanie reminded us that maybe to type them into the chat. That might be the easiest way to do that.
Okay, I think we can go on with the next presentation.
All right. So if no questions, then I'm happy to introduce Patty Vega Fernandez, who is joining us from Colombia, if I'm remembering correctly right now. Patty is an assistant professor in the Division of Rheumatology at CCHMC, the Children's Hospital. So welcome, Patty. Thank you.
I think now you can hear me.
Yes.
Yes, we can hear you and we see your mouse moving. Yes.
Okay. So I was saying I'm excited to be able to present what we've been working on the last few years, and it's about an ultrasound scoring system for arthritis. So to call the attention, let's talk about first arthritis in children. We call that juvenile idiopathic arthritis, and for us it's very important because it's the most chronic rheumatologic disease in children, and it's just an umbrella diagnosis. So this diagnosis encompasses a different group of childhood arthritis that are chronic and present before the age of 16 years of age. And I wanted to remind that arthritis is a clinical diagnosis, which means a clinician determines the presence of either joint swelling or joint pain along with limitation of motion. We obtain a lot labs or sometimes like x-rays, and that will help us for classification criteria and maybe talk about like exclusion criteria and prognosis. And it's a diagnosis of exclusion, which means as a clinician, you need to be certain that when you're assessing the presence of joint inflammation, that's what it is present. In the past, we thought that JIA was a disease just of children, that they could outgrow it. But right now, we know that about 2/3 of kids that had arthritis, depending on the subtype, the category, they can continue having significant functional impairment as they grow. So I am sorry. Give me 1 minute here. Now I'm back, and hopefully you had time to assess these couple patients here. And so we see, I think it's quite obvious the difficulty, like the little one is having moving up the neck related to arthritis, or how he's standing up. And the child on the right side of your screen, we see how she is with one holding one leg different from the other, that is related to leg length discrepancy. And also abnormalities like on different joints. So these are obvious findings, but a lot of times as a clinician, it's hard to detect those. So clinically, we are not able to determine if there is presence of joint swelling, or what we're feeling is like inflammation on the tendon or tenosynovitis, or if there is presence of subcutaneous edema. Also, when you look the interrated reliability between clinicians to determine presence or not of arthritis, that reliability is very limited, only between 0.3 to 0.5. And the clinical examination, we're not able to determine if the inflammation, the severity of inflammation or chronicity. Then we saw that there is a need for improved strategies to detect the overall burden of joint inflammation in JIA. So this was where we saw a potential role for imaging in helping that clinical decision making and supporting the care of these kids. And when we talk about imaging, we have two techniques. We have MRI, which is very sensitive and can detect even areas of like bone marrow edema, which talks about like severity and maybe chronicity along with erosions. But however, it is can be expensive. Is time consuming, and depending on the age of the patient, you might need sedation, and it's not available in all different settings. Then we have ultrasound. That is something that we can do in clinic. It's widely available, it's time efficient, and it's very important for us, it's child friendly. However, it can be operator dependent. And in pediatric rheumatology, there is no standardization for like a scanning protocol or a scoring system. So it was in this area that we have been working in recent years. And so in that, trying to propose some standardization was when a group of us, led by Dr. Ting here at Cincinnati Children's, started working especially on a scoring system and a scanning protocol for the knee, that is the most common joint affected in JIA. And so we determined that we take 3 different views with ultrasound as shown in this cartoon. And then we propose a scoring system for this scanning protocol, just to be able to have a standardization about the severity and to be able to describe the findings better. So with this in mind, the next step was to further validate, and that's what I've been working on my KL2 project, in which my validation, in which I'm looking into the convergent validity of this post-knee or the pediatric arthritis scoring system of the knee when we compare with physical examination. Also, we wanted to see how this scoring system performed when we compare to contrast-enhanced MRI of the knee, looking for presence of disease activity and disease severity. And we wanted to explore the correlation of the scoring system with biologic markers of inflammation. So for this work, we have been enrolling patients with JIA and active knee arthritis by physical examination. And these patients are to receive a localized musculoskeletal physical examination. All of them get an ultrasound of the knee, and we have proposed to obtain 50 knees total for this project. And along with the different interventions are questionnaires assessing symptoms of disease severity, physical function, and quality of life. Of those subjects, we are to perform 25 MRIs of the knee with contrast, and only patients that will have a clinical indicated procedure, such as joint injection, we will be collecting synovial fluid and serum. So I'm going to show you some of my preliminary results. We have been able to enroll a total of 67 children from age 2 to 18 years. And all of the clinical information and questionnaires have been collected successfully. So at this point, we have a total of 107 knees for ultrasound, and we have been able to collect 22 MRIs of the knees. The study has been very well uptaken by the patients and providers. And we actually been able to collect 17 synovial fluid samples, which is a very rich the data set that we're being able to build. And along of that, 6 serum samples. And here I'm just gonna show very like preliminary analysis. And we're finding that our scoring system for the knee has a moderate correlation against clinical arthritis. And this is somehow not new, but it is very important to highlight that as a clinician, we might be missing presence of what we call subclinical arthritis, which has been described before. But what we are excited to see is that the scoring system has a strong correlation when we compare with contrast-enhanced MRI. And so our findings so far are suggesting that the scoring system of for arthritis of the knee has a potential to support the clinical decision making in JIA. Our next steps. So we are right now in the process of analyzing the synovial fluid and completing our studies to be able to assess the detail of this validation for the knee. And after that, we're actually working on the validation of the scoring system for all the other key joints in JIA, which includes the finger, the wrist, the elbow, and the ankle. We're also working to determine a limited ultrasound examination in JIA. So maybe if we scan only 10 joints will be enough to support the clinical assessment. And also we wanted to look into the correlation of these scoring systems with biologic markers of inflammation. And we're looking for longitudinal studies to determine the validity and the cost effectiveness of the scoring systems and its use as an outcome measurement. With that, I would like to acknowledge my team of my CRCs, collaborators, mentors that have been essential for my work here, and all patients and family for my KL2 program. So thank you very much.
Great, thank you, Patty. Just a friendly reminder to type any questions into the chat. I don't see any there at the moment, so why don't we go on to our last presenter. Tim Dribin is an assistant professor in the Division of Emergency Medicine here at the Cincinnati Children's Hospital. So welcome, Tim. Thank you.
You see my slides, my first screen?
Yes, we can. They're in the side-by-side version, though.
How do you get it out of side-by-side?
I don't know the answer to that, unfortunately. Might be that third button over.
You should be able to hit present. Where's the Display settings, under display settings. Yep. Swap.
With the slideshow.
Yep,
Is
there
that
you
good?
go.
I got
Yep,
All right.
you got it.
All right. Well, thank you all for letting me present here today. You can see my title of my presentation there. I have no conflicts of interest to report, and this is the funding that I've received through the CTSA and the KL2 program, which I'm very indebted to. I am an anaphylaxis researcher, clinical and translational researcher, and just for folks who are not aware, anaphylaxis is a severe, potentially life-threatening allergic reaction, and the first-line treatment for anaphylaxis is with epi or EpiPens, as you probably heard in the public. My mentor in 2006 through the National Institute of Allergy, Infectious Disease, and the Food Allergy and Anaphylaxis Network developed the criteria for anaphylaxis, and it is a clinical diagnosis. And classically, we think of it as a systemic reaction, a multi-system disease. So patients who have two organ system involvement, so trouble breathing and vomiting and allergen exposure, or patients who have isolated cardiovascular involvement. The pathophysiology of anaphylaxis is still, there's still a lot of questions to it. It's a very heterogeneous condition. The main effector cells are mast cells and basophils, and the mediators that are very actively involved are histamine and tryptase. And I'll get to these later because these are the biomarkers that we're assessing in my study. We see a lot of emergency department visits for anaphylaxis. This is group work that our group did showing that from 2008 to 2016, there was a twofold increase in visits among all ages, and then pediatric visits increased threefold. We see at Children's almost 300 visits a year for anaphylaxis just at our main emergency department, and up at Liberty, we see a lot as well. So almost every day, kids come in with anaphylaxis. And these visits are very burdensome for the children, their parents, and they're always worried about having future reactions after accidental exposures to foods, which are the most common cause of anaphylaxis in the pediatric population. What's challenging about anaphylaxis is there's very different clinical courses, and it's not a consistent condition, and it's very hard to predict what happens with these patients. So I have just a few images to show how difficult this is. Now, most children with anaphylaxis, they get epinephrine and then their symptoms resolve, which you can see here, and that's the majority of cases. There are some kids, though, that have these persistent, protracted symptoms that last, greater than 3 to 4 hours or even longer. And those kids, obviously, we don't want to send home too soon because we worry that their condition could worsen and they may need additional doses of epinephrine. And then there's another group of children that, despite given multiple doses of epinephrine, their symptoms persist. And these are usually the children that are admitted to the intensive care unit. They may have shock. They may have respiratory failure. This is uncommon, but there are a subset of these kids. And usually these are pretty easy to identify because they come into the emergency department and they're quite sick on arrival or within the first 30 minutes of arrival. And then the last kind of clinical course that has most emergency departments and allergists kind of nervous about is this condition called biphasic anaphylaxis. And our group in 2021, I led a national group of allergists and emergency medicine doctors to define this. And what this is patients have their initial reaction, their symptoms then completely resolve, and then after a period of time, their symptoms recur. And obviously, we don't want to send children home, and this happened at home for families in case that they could have a bad outcome. So this is the thing that we still don't know the exact risk factors or when it is. And there are some institutions around the country that are so worried about this that they hospitalize all children with anaphylaxis to monitor for these potential biphasic reactions. So the question then is, how long do we observe children? Which children should get observed? Do we base it on when their symptoms resolve? Should that be the gold standard? Can we send kids home who have mild symptoms, maybe a rash that still is there? Or really is the optimal outcome, no need for additional epinephrine doses? Because if you don't need epinephrine, the other symptoms are probably mild. Here at Children's and around the country, as emergency medicine doctors, it's a fast-moving place. We like to have a one-size-fits-all approach that's easy to remember. So we watch all children for 4 hours, no matter how severe they are. And this is contrary to the heterogeneous condition that we treat. So it doesn't make sense that a kid with a mild reaction who is almost asymptomatic when they arrive to the emergency department after giving epinephrine needs to be watched for 4 hours, whereas a kid who's more severe would be watched for the same period. So there's need to kind of develop tailored observation periods and hospitalization criteria that account for the reaction characteristics and patient comorbidities. So this is kind of a diagram to kind of show what we really should be doing is, developing prediction models that can account for these different clinical courses. So children with less severe reactions are observed for a shorter period of time, and those with more severe persistent symptoms are watched for a longer period of time. The limitations of anaphylaxis research, it's very hard to enroll these kids in real time, as you can imagine. Emergency departments are chaotic, busy places. Families are stressed when they come in. So it's challenging, it's expensive, it takes a lot of CRC time to enroll these. So there's a lack of prospective data to inform observation periods and about management strategies. And anaphylaxis is a clinical diagnosis. We don't have reliable diagnostic and predictive biomarkers to confirm the diagnosis when there's diagnostic uncertainty, or to help improve management decisions, including when to give epinephrine and how long to watch patients. So that leads me to my KL2 work, and I started my KL2 last April. So the first aim was to determine timing and predictors of symptom resolution among children presenting to the emergency department with anaphylaxis. What we hope is we can develop tailored prediction models based on reaction severity and clinical characteristics to hopefully shorten observation periods for a lot of children and prevent unnecessary hospitalizations. The second aim is to validate the association between biomarkers, tryptase, plasma histamine, and urine histamine with symptom severity and adverse anaphylaxis outcomes. So for those refractory kids and kids with biphasic. And then given that it's so time intensive and expensive to enroll these kids, we want to make sure that we're biobanking samples so we can accelerate future research. So the study procedures, our target sample size is 100 patients with clinical data, and then we wanted to enroll 50 patients with biosamples over 2 years. Just to show the complexity of this, in the emergency department, our CRCs perform 4 sets of surveys during ED care, and we have 3 follow-up tech surveys that go home to make sure that we capture the out-of-hospital course, and that families participate in a 1-week follow-up survey with our CRCs. During the emergency department care, we assess symptom severity, the duration of symptoms, and recurrence of symptoms. We look at therapies, and then we also ask providers and families questions about their comfort and decision making. And then we collect 3 sets of samples during patients' time in the emergency department: tryptase, plasma histamine, and urine histamine. And then we're also biobanking those samples. We're collecting extra blood and urine samples as well, and then developing a microbiome repository. And then families who have consented biosamples follow up in our Schubert Research Clinic to provide patient-level control samples about 4 weeks after their index emergency department visit. So our study progress thus far, we've enrolled for about 5 weeks. We have already enrolled 12 patients in about a month, and 8 of those have provided biosamples. So this will be the first pediatric translational study of anaphylaxis ever conducted, and we're really happy with our enrollment so far. So our next steps are, I'm planning to submit a K-23 to really enrich our biorepository, to enrich our cohort, and to apply some different statistical analysis to the patient population, which we're very excited about. And we're one of the things is we want to explore the role of different effector cells during anaphylaxis, given that for a lot of these kids, for whatever reason, some of the biomarkers are not elevated in food-induced anaphylaxis. So we think neutrophils may have a significant role in anaphylaxis and may offer a potential therapeutic target. The impact with this, we hope to standardize and reduce observation periods, prevent costly hospitalizations, and hopefully one day actually be able to have kids stay at home with anaphylaxis and not need to come in if their families are savvy. And then we want to identify combinations of biomarkers that we could use and to translate into clinical care to improve decision making. And then what I'm really excited about is I have a multidisciplinary research team that's helped develop this study and the future work. And I'm really excited about working with a multidisciplinary team to accelerate future anaphylaxis research. So I want to say thanks to the KL2 program, the wonderful leadership of Dr. Khan and Blackard and Krista, and then also my peer mentors in the program. I'm very thankful, the CCTST, Children's, and my institutional support, and my wonderful research team. And then lastly, my amazing mentors, David Schnadower in my division, and Hugh Sampson, who's at Mount Sinai. So that's all I have.
Thank you, Tim.
Yes, thanks so much, Tim. Thank you, everybody. Thank you for our presentations, of course, and thank you, everybody out there, for being so patient with our initial IT issues. I think we all agree it was worth the wait. And although we didn't have any Q&As today, I wouldn't hesitate to follow up with any of the scholars if you're interested in asking questions or otherwise engaging in their research. It's all really incredible, and they're enthusiastic and would be happy to talk about it. Stephanie put the link in the chat for the survey, and here it is in the slide as well. So please take a few minutes to fill it out. And thank you again, everybody, for your time today. We look forward to seeing you next month.